We'll get started now. So welcome everyone to Genomind Grand Rounds. My name is Dan Dowd. I'm the VP of Medical Affairs here at Genomind. The title of today's Grand Rounds is Management of First Episode Psychosis. So we're lucky enough here to have Dr. Craig Chepke with us. He's the handsome fella at the top of your screen there. Little background about our Grand Rounds. We've been doing these at Genomind for about a year now. These are part of our Genomind 360 platform. That's an educational platform that we have. All of our previous Grand Rounds are hosted and they're live on this Genomind 360 platform. We have webinars, we have educational materials, we have one-pagers. Feel free to visit that at your leisure. It's genomind.com/360. And again, all of our Grand Rounds, including this one, will be posted there tomorrow. So a little logistics before we get started here. This is the Zoom webinar, which means we are unable to see you and unable to hear you. So if you want to communicate with us, use the Q&A function at the bottom of your screen. We'll be monitoring that Q&A throughout the webinar, but we plan to hold all questions until the end of the webinar. So we're aiming for a 45-minute presentation by Dr. Chepke and 15 minutes of Q&A. Okay, so that's enough about logistics. Let's introduce our speaker today. So Dr. Chepke is an MD, board certified psychiatrist, and has been named a fellow of the American Psychiatric Association. He attended NYU School of Medicine and completed his residency training at Duke. In addition to his clinical practice, Dr. Chepke is an adjunct assistant professor of psychiatry at the University of North Carolina School of Medicine. Dr. Chepke has special interests in treatment-resistant and severe mental illness, movement disorders, and sleep medicine. His approach is to personalize treatment to each individual, from the newest leading-edge medications to older, underutilized treatment, such as lithium and clozapine. He also strongly emphasizes psychotherapeutic interventions and physical health and wellness through exercise, dietary modification, and supplementation. He's active in clinical trials and serves on the board of directors of nonprofit organizations benefiting schizophrenia and Huntington's disease. He and his wife, Tiffany Chepke, a therapist, started Excel Psychiatric Associates, PA, in 2012 in Huntersville, North Carolina. So with that impressive bio, I will now hand it off to Dr. Craig Chepke. Thank you.
Well, thank you for the introduction, but I think he's spent about half of our 45 minutes on it. So in all seriousness, though, everybody, I really appreciate you taking the time to log in today. In the respect for your time, then I definitely want to get us done by the top of the hour. So probably might cut some from presentation time to be able to really enable a good, robust Q&A. That's always my favorite part of any type of presentation. So please do, don't wait till the end. Please do fire away with questions, put them into the Q&A, just as mentioned previously, and then we'll get to them at the end. So we're gonna go ahead and get started, but not before add a couple of disclosures. So as you can see, I do work with a number of pharmaceutical companies in some various roles, but there was not any sort of assistance or input into this slide deck from anyone, and that includes Genomind. I should say that the presentation is not for any continuing medical education, because this is a promotional program essentially sponsored by Genomind, and I'm being compensated for the time that I'm spending giving the presentation. They did not have any input. They didn't even ask me to talk about pharmacogenomics. That they give me free reign to talk about whatever I want to in terms of first episode psychosis, which is very exciting. So if you have any questions about these disclosures, feel free to ask. So just a touch of things that you probably already know a lot about. The schizophrenia is not a particularly prevalent disorder. The prevalence numbers historically we had been taught were around 1%. Because of some ways that they had changed the accounting for the statistics, the numbers are a little bit lower than that. But if you said 1%, I don't think you'd be wrong. The characteristics of schizophrenia are more than just a brain disorder. We'll talk about many of the different characteristics of dysfunction in the central nervous system, But there's clearly more than just that. The mortality of schizophrenia is dramatically increased over that of the general population, and not just due to things like suicide. Suicide risk is tremendously increased in people with schizophrenia compared to the normal counterparts, but there's also significant other pathology that we have to attend to as well. There are a couple different the characteristics in terms of age and things like that. People with schizophrenia generally will manifest in the late teens, early 20s, at least in males. In females, it can manifest a little bit later than that. There are a couple other differences that we could tease through, but really I think that the meat of the presentation is yet to come. Now, everyone always wants to know, well, what is it that's making me sick? Do I have the depression gene? Do I have the bipolar gene, the schizophrenia gene? And what we have to tell them is, of course, there is no such thing. That you could think of it similar to other significant illnesses. Let's say cancer, that's one that most people are familiar with. Most people understand that in general, cancer is not just one gene that goes wrong, that there's a tremendous number, dozens, hundreds, who knows, that have to coalesce and come together for someone to get cancer. And then it's more than just the genes, right? Because we have other aspects. Well, what about people who smoke cigarettes? Well, that can also lead to an association with lung cancer, but not everyone who smokes gets cancer. So there's a variety of different interplaying factors that go towards any diagnosis, and certainly schizophrenia would have to be one of them. That we clearly don't know what all the risk factors are. There's definitely got to be some high-risk genetics, and then some risk factors that are not modifiable by that person. Could be things such as maternal illness, etc. Modifiable risk factors on the patient's part, a lot of it has to do with potentially, at least I should say, could be some of the lifestyle choices that the patient has. Do they use substances? Do they drink alcohol? Do they smoke cigarettes? And those are aspects that I think flow into the top box up there, as well as socioeconomic risk factors. In general, most people with schizophrenia do have socioeconomic disadvantages, and that can play into some of the modifiable risk factors. I didn't put an icon of a Big Mac here, but unhealthy eating is generally associated with lower socioeconomic statuses. And unfortunately, those cannot be so easily modified by people in those situations. So we have to consider a broad number of inputs that go into the diagnosis of schizophrenia, and that will inform, hopefully, how we are treating schizophrenia. Because if it is a broad spectrum combinatorial risk profile that causes someone to have schizophrenia and to suffer from its consequences, we're going to need to pay attention to combinatorial approaches in order to manage that patient and not just focus on genetics. So what is the typical course of schizophrenia? This is one take on a diagram that I'm sure everyone watching is familiar with. And it starts off in the pre-morbid phase before anything goes wrong, so to speak. And I should say, I don't honestly know what our audience is made up of. Could be physicians, could be NPs, PAs, therapists, case managers. My wife is a social worker, so I hope we do have a multidisciplinary treatment team out there. Who knows? Perhaps there's even some people living with schizophrenia or some of their family members. So I'm going to do my best to cater to every audience here, because I don't want to go over detailed and make it not accessible and not interesting or relevant to people without a significant degree of specialized training. And on the other hand, I don't want to go too broad and not make it interesting to some of the more advanced listeners that we have today. So that's one place that the Q&A will come in. If I blew through something that was confusing to you, ask a question. If I didn't go into enough detail about something that was interesting to you, ask a question. So I wish we were face-to-face in person so we could have interactivity, but this is the best we can do. So the pre-morbid phase, we don't know that anything's going wrong with the patient as yet. And then the person enters the prodrome, where this is something that's generally only known to be the case in hindsight, and it has a decline to some degree, and then leads into the first episode. Now, first episode psychosis was the title to this presentation, of course, and we're going to spend most of our time about that. But we also have to look at it through the lens of the context of possible evolution into schizophrenia. Not everyone with first episode psychosis goes on to have the disorder of schizophrenia, but I think we should consider that as one of the common outcomes. And so we will have some places in which that we will talk about the full syndrome, the full diagnosis of schizophrenia, which again may or may not be applicable to every person who suffers first episode psychosis. So some nuances that I want to highlight in here. In the first episode, notice that V-shaped recovery. There's a term that we've heard a lot over the past year, isn't it? That we always hope for a V-shaped recovery. And people in the first episode of psychosis tend to show a pretty robust resolution of their symptoms, that they have a relatively quick, rapid, and nearly full recovery from that initial first episode. That's a good thing and a bad thing. The good part of it, I think that's self-explanatory, but what could be bad about having a robust, quick recovery from a really devastating illness? Well, think about it from the patient's lens of view, from the family member's point of view. You rotate that around and think, well, hey, this was really bad, but I got on some medication and it got better really quickly. What if this never happens again? Maybe I don't need to worry about this. Maybe I don't need to take medication. That is a dangerous and unfortunately all too common perspective that occurs in these first episode patients and their family members, is that quick recovery can be misleading, that they may believe that that they may not have a relapse because it was a potentially relatively easy recovery. And even if they are willing to buy into the fact that this may be something that they could have to deal with for quite some time, think, well, it was so easy to get over it the first time. What's the big deal? I can go off of the meds now, and if I have another episode, I'll just go back on meds and I'll pop right back to normal in a short period of time like I did the first time. If only it was so easy. And it's listed here as the critical phase for a good reason. It's critical. This is the period of time for a couple of reasons that really can help set the course of the person's lifetime. Again, assuming that they were to proceed on into a case of chronic schizophrenia. For the people who never have another episode of psychosis, and Yahtzee, they get out of jail free, so to speak. But we have to consider that this is going to be a chronic condition for many of the people who suffer a first episode. Again, we can go into some more details. The two most common answers that I give to any question really are, it depends, and it's more complicated than that. And neither my wife nor my patients like those answers, neither do people that I'm teaching generally, but that's just how it is. There's always so many variables. So I'm just gonna kind of pick some of the common themes. And again, if you have questions, throw them in there. So the critical phase starts, you can see, before the first episode. We're going to blow up in just a minute on the first episode and look at the course of that, a typical course. But notice that it starts during the prodrome. That is also critical. And it's critical for a number of reasons, and not the least of which is there's the concept of something called DUP, or duration of untreated psychosis. This is, by most research, although not universal, believed to be a critical marker of the patient's long-term prognosis. That when the person begins to have the illness in the prodrome, that they can easily go undetected, undiagnosed, or misdiagnosed, I would say most commonly in my experience. And that when they start to develop psychosis, that if it goes untreated is very detrimental to the patient. We'll look at some evidence for that in just a couple of minutes. Then the first episode, we want to make sure that they get treated. And then there's the critical aspect of the maintenance treatment. Again, some people will not go on to have more episodes, but the vast majority of people who have a first episode of psychosis will have a second episode and a third episode and a fourth episode, and who knows how many. And you can see from the latter half of this chart that it doesn't look as rosy as it did with the first episode. Even starting with the second episode, you can see that they hit bottom and then they stay there longer. We no longer have a V-shaped recovery. It doesn't have a good letter to correspond with it, so we'll leave the letters behind. But you can see that it takes quite a bit more time proportionally for them to get better. And the rate of the recovery is not as steep, and also they don't rise to as great of a level of the functionality. And that's something that we see continuing to go down with each repeated relapse. The person never quite achieves their previous level of functionality. There's the old saying, you can't go home again. That's more or less the case when it comes to schizophrenia and repeated psychotic relapses. The patient is almost literally burning through brain cells, and we need to make sure that we prevent as many of these recoveries as we can, many of these episodes of relapses as we can, and trying to keep them in recovery. Now, if they can't get to a full recovery, we want to make sure that we maintain them in at least a partial recovery. Eventually, after some number of episodes, they settle into a chronic phase very often where, again, you can see it generally doesn't progress infinitely like many neurodegenerative diseases, Alzheimer's, Parkinson's disease, etc., but it is notably at a much lower level. So we want to prevent this, obviously, right? We want to keep our patients at the highest level of functionality possible. And we can do that by preventing the recurrent relapses. So here's a magnification of that period of time right around the first episode, as I mentioned. The length of time of the prodrome is variable, of course, but can often be 5 years. So similar to other neurodegenerative diseases, there's a prodrome period which long predates the first classic sign of the illness. In Parkinson's, when someone gets a diagnosis of Parkinson's, is when they have enough tremor or enough clumsiness or other motor manifestation. However, looking back in PD, you can actually see the prodrome can begin 15 to 20 years before they have the enough criteria to make it the diagnosis motorically of Parkinson's disease. With schizophrenia or in the first episode, psychosis, then you can see 5 years before. So what's happening during these 5 years? Well, a number of different things, but you can see, well, actually, I'll leave this for a subsequent slide, but things start to go off course, but it's not psychosis. And schizophrenia, by the epidemiology that we looked at, being not a common illness, it's easy to think, especially when you think of the time frame. If the average person has their first episode of psychosis in their late teens or early 20s, then 5 years prior to that, this is someone who's in usually high school most often. When they start to have some withdraw from their activities, from their family, they have some concentration difficulties, some mood disturbances, some irritability, a variety of different symptoms. Schizophrenia really can be almost like a chameleon, the disturbances that someone has psychiatrically can take almost any form. We learned in medical training that when you hear hoofbeats, think of horses, not zebras. So that's why I said it's so common for people to get misdiagnosed when they actually have schizophrenia. And what happens at that point is when they get to the psychosis, which can be another year or two after the prodromal period. And well, at first after the prodrome ends when they cross a certain psychosis threshold, which is arbitrary, but they tend to have an attenuated psychotic syndrome at that point. That they have some kind of parapsychotic beliefs that are mild and enough to kind of evade detection, to be explained away by other explanations, but then things rapidly progress to where they have an undeniable psychosis. Unfortunately, the misdiagnosis can continue at this point because in many cases, someone will have the attentional difficulties in the prodrome, and they'll be placed onto a medication, a stimulant for attention deficit hyperactivity disorder. Because by virtue of the English language, people who have difficulty with their attention believe that they must have attention deficit hyperactivity disorder. That includes patients as well as many healthcare providers as well. So it can be easily explained by, well, you know, they're on a psychostimulant. Maybe that's why they have psychosis. Maybe they accidentally took a little bit too much. We need to just pull them off, lower the dose, something like that. Many different explanations. Generally, when I see patients and make the diagnosis of schizophrenia, they've generally shown up in the mental health care system in various ways. often in ER visits or urgent care visits, sometimes hospitalization, sometimes suicide attempts, and still many of them escape the diagnosis. Very, very frustrating on my end as someone who treats many people with schizophrenia that that the diagnosis is not made sooner. But anyway, we can get to that more a little bit later as well. So it's really the positive symptoms that cause us to generally make the diagnosis of schizophrenia. But we definitely don't, we aren't so lucky, people with schizophrenia aren't so lucky that those are the only symptoms. There are significant other symptoms of schizophrenia listed here, and we will talk a little bit more about those as well. I'm not going to read through the DSM criteria for schizophrenia, put them here kind of for completeness, but also to point out that piggybacking off of the last two graphs, which I showed you, which hopefully you remember, there's a long lead up to when the person has their first true breakthrough psychotic episode. If you look down at the third main bullet point, that this signs of the disturbance persist for at least 6 months. Well, that 6 months does not only encompass the florid psychotic symptoms. That includes the prodrome. And then, as it mentions down below, though, at least 1 month of symptoms, and by that we should be thinking of psychotic symptoms, however, less if successfully treated. So if someone comes in, they have, say, a week of florid psychosis, they get placed upon an appropriate antipsychotic agent, and the psychosis recedes. If we were so lucky, if the patient was so lucky, then that still counts, that still would qualify for the diagnosis of schizophrenia. Now, you do have, of course, have to do some rule outs, but again, I've found that many people grossly over rule out schizophrenia in relationship to another diagnosis. Sometimes I think of it like it's the cancer diagnosis for psychiatrists or psychiatric providers. No one wants to give a cancer diagnosis in medicine, and most mental health providers don't want to give a schizophrenia diagnosis many times. It apparently seems much more, much easier or lighter. It doesn't seem quite as judgmental, perhaps. Who knows, to give a diagnosis of bipolar disorder when it's actually schizophrenia, of substance-induced psychotic disorder when it's actually schizophrenia, of pretty much anything else but schizophrenia. And this is directly harmful to the patient. We can't just allay our own anxiety and give a diagnosis which is not accurate because we're afraid to have that conversation with the patient, with their family, and make the hard call and do the hard right thing that is going to help the patient to achieve their best life. So that's all I'm going to say about the diagnosis. Really, anyone almost can make a diagnosis of schizophrenia if they come in dramatically psychotic. But again, we need to shift that up forward. There is the concept of the clinical high risk stage and the ultra high risk stage, which I think was a little bit much for this presentation, so I didn't include it because I didn't want to go too in depth. But we need to do a better job of identifying this illness earlier. And that includes being able to look at the prodrome and really recognize it sooner and recognize there's something going wrong. There's two different ways that the prodrome is experienced. First is the external observation. What do the people in the person's life see? And then what do we as healthcare providers see? Well, it begins with that they just have kind of a vague, non-specific change in thoughts or feelings. Maybe they're just having some, it could be written off as, oh, they're going through a phase. The things are starting to change, that there's been a bend in the curve of that person's lifeline early on, and indicated by number 1 there. It's kind of vague, non-specific anxiety, could be depression, poor concentration, sleep disturbance. Again, like a chameleon, could mimic almost anything. One patient of mine that I used to serve, he unfortunately died by suicide almost 3 years ago now. It'd be three years next month. His first prodromal symptom was an eating disorder, actually. And at the time, who would have ever thought that was schizophrenia? But in hindsight, that's where we were able to trace it back to. So that's early in the prodrome. Later in the prodrome, you start to get the attenuated psychotic symptoms, as I mentioned. It starts with a vague sense of paranoia, ideas of reference, potentially. Perceptions can be a little bit different. And they just don't seem to be able to communicate with the people around them as well as they used to. They might get preoccupied with certain new ideas that they just can't stop thinking about, which had never really been concerning to them before. And then it progresses on to not being able to function as well. They don't have the same level of self-care in terms of grooming, hygiene, etc. And then they have a role failure. Maybe they were a very high functioning person, that they were a great student, did very well at work if they were in the workforce at the time, and then they regress. They lose some of that potential that they previously were showing. Their trajectory markedly changes. And then there's the social withdrawal, that they start to pull back. Again, as I go through this, cases just flood to mind of patients that I've dealt with. A young man who was a high school football star, went on to play college football, but right around that transition between high school to college, started to have some difficulties with concentration, had been an outstanding student, and it became more difficult. Well, college is harder than high school, right? So maybe he's just now showing ADHD. He got on some stimulants. He started to withdraw from family, from friends, actually dropped out of the football team. They quit the football team, which was shocking to everyone around him. But you can see his life started to bend in the wrong direction. Self-care diminished. He became malodorous, wasn't showering. He just didn't seem like the same person as how family described it. Got multiple diagnoses, depression, ADHD, etc. That's what's seen on the outside. But now think about what the person has on the inside. What could lead someone from having a normal, quote unquote, life experience to having that of psychosis? Well, it begins often with internally just a delusional mood or atmosphere. They just have this vague sense of something's up. Something's not right here. I don't really know what it is, but I feel like something's wrong. This isn't how it's supposed to be. And then often that they'll begin to have, I call it a eureka moment, like, I knew it, that's what's wrong. They'll have a abnormal salience, it's called, that they'll attach a much greater degree of significance to coincidental or meaningless experiences than should be granted. And that's the explanation. That's why I felt something was wrong. I knew something was happening, and that confirms it. I can proceed into delusions of reference, that they can believe that the television is giving them messages, radio songs are about them, that the young man with the football player, that was, he believed that many of the songs on the radio he heard were about him. And then finally, of course, the acute psychosis with a very strong affect. They really have a tremendous affective change when that psychosis hits very often. So these are, I tried to add some color and some interest to them, but these are fundamentally just dry lists of symptoms. If you really want to get a much richer take on what it's like to see someone go through the first episode of psychosis, these would be the resources that I would recommend for you. It was mentioned that I'm on the board of directors for schizophrenia nonprofit. It's Secures organization. A comprehensive understanding via research and education into schizophrenia is what the acronym stands for. Co-founded by a woman named Bethany Yeiser, who has schizophrenia herself, and one of her psychiatrists that she worked with, Dr. Henry Nasrallah. They co-founded the organization in, I believe it was 2016. And Mind Estranged, the book on the right, is Bethany's memoir, where she discusses her journey. And Flight from Reason is her mother's memoir. So you can see the internal and the external perspective of the transition through schizophrenia, as stated on the book, homelessness, and then recovery. I would try not to tell Bethany's story for her, but it's such a compelling story. It's really just a perfect microcosm of why we shouldn't have perceptions and mischaracterizations about what schizophrenia is and who the people who live with it are. Bethany was top of her class, concert violinist, had published neuroscience papers as first author prior to going to college. She went cross country to a very highly regarded university, was working in a research lab, did excellently her first several years of college, and things started to change. There was a mission trip she took overseas, and the delusions started to take hold. And Eventually, she, after her third year of college, had a full psychotic break and became homeless. She first lived in the libraries and then eventually on the streets in a park by a church, and was taken to the drunk tank more or less several times by police when there was a disturbance. And then finally, after several of those incidents happened, then she was brought to, the officer said, I don't think she's a criminal. I think she's sick. We should take her to get a psych eval. And what I love about Bethany's book is that you can really see that line of how the thought processes start off normal and ever so slightly it bends towards delusion. And as she talks about, how do you find the line between normal and abnormal? And to see it from firsthand is really illuminating. These books actually are required reading for any patient that I see with schizophrenia. I keep several copies on my bookshelves, and I'll give them out if I need to patients to borrow or to keep. And then now, while all this is happening to Bethany, she was completely cut off. She cut herself off from her family. They didn't see her for years. They didn't hear from her whatsoever. They were across the country. They tried to find her. They couldn't. Finally came together when Bethany got the diagnosis of schizophrenia. And I go through her story because of what happens next. And when her parents finally met the psychiatrist who had diagnosed her, said, now I know that Bethany, you had a lot of high hopes for her. She was a very high achiever, but she has schizophrenia. And so you need to lower your expectations for her. And I'm just going to sit there and let that sink in and let the goosebumps and the tears pass. The first time I heard that story from Bethany while I was actually interviewing her on stage, and I did almost cry there for sadness and outrage that is what we think of patients with schizophrenia, that we have such low expectations that we believe that it is inevitable that someone who suffers from the disease of schizophrenia is going to be permanently disabled. That's another term that was used by the psychiatrists at the time, that you're going to be permanently disabled. Bethany eventually, after working through several medications, about 4 or 5, got to Dr. Nasrallah, put her on clozapine, and she has been in complete remission from schizophrenia for over 11, 12 years, something like that. Enough that she's co-founder of this organization, travels the country as a motivational speaker. So we need to raise our expectations for people with schizophrenia, because if we don't believe in our patients with schizophrenia, how are they ever going to believe in themselves? And we need to have a recovery-focused attitude. So that's what we're going to start to turn to in just a minute. So I'm going to actually probably skip past that. I see time is slipping away. As always, no matter how few slides I make, time always slips away. We need to get better at recognizing the negative symptoms. Again, as I said, the positive symptoms are comparatively easy to determine, and getting more familiar with the negative symptoms is critical to making this diagnosis sooner. We also need to pay attention to cannabis. Cannabis is legal either recreationally or medically in many parts of the country. Others, like in North Carolina, where I am, there are no legal forms of it. There is significant evidence that cannabis use in any form can significantly increase the risk of developing schizophrenia. Now, this is not a value judgment. This is not a moral judgment. I have none of those feelings towards cannabis or honestly any illegal substance. However, as I tell my patients, as your doctor, I just need to know what's going into your body, and you need to know what's going into your body. Like it or not, medically, there is an increase of risk. So it is not a harmless substance. Natural sometimes just means unregulated. So in terms of treatment of people with schizophrenia, and then more specifically first episode psychosis, the field was greatly improved by the APA finally updating their treatment guidelines for patients with schizophrenia in the past year. So pulling out some of the highlights of that document, which is very long and comprehensive, that are persistent to first episode, as I mentioned, they may respond more quickly. But critically, though, they may require a lower dose than later episodes do. So we don't want to think of people with first episode psychosis the way we do with chronic schizophrenia after a number of relapses. If we try to use those same paradigms, then we are not going to have good outcomes. They are going to be on more medication than they need, and that, as you can expect, would lead to more likely to develop side effects. And unfortunately, they're even more likely to have side effects in first episode compared to more chronic patients. And that's including metabolic side effects, but as well as motor side effects, what many in the mental health field call extrapyramidal symptoms, or EPS, a term that I recommend that no one use. Go ahead, ask a question. I'm going to stay off that soapbox unless someone asks a question. But people with first episode are more likely to have those than the average patient. So we really need to be cautious about how we're dosing the antipsychotics in people with first episode psychosis. Doing what we would normally do using a cookie cutter approach is not going to go well. One thing I also want to highlight is, how do we get to those high doses? Well, we're impatient. As a society, as a culture, this is America, bigger is better, right? Well, that doesn't always work for sure. Certainly when it comes to first episode. Another influence here, and having done a number of years of inpatient psychiatry, there's tremendous pressure from managed care that if you don't make a medication change, they're going to deny the visit. So often doses can go up very rapidly if we don't see a benefit in a very short period of time, i.e. a day or 2 days maybe. But we need to give patients more time on the medications and not just have that rapid knee-jerk response to continually increase the dose, add more medications. Patients can take 2 to 4 weeks to show an initial response, and longer potentially to have a full response. Again, I'll just stress, this is not an opinion slide that is reflecting my personal opinions. This is the APA guidelines talking here. So we need to be cautious. We need to cradle patients with first episode in our hands gently and treat them delicately. And if they do have a response at that higher dose that we escalated too quickly, how do we know? How do we know that it was because of that dose increase, or just that we finally gave them enough time that a lower dose would have worked well? Also, maybe that could give the impression to us, to the patient, that it's due to that higher dose and they're going to keep needing higher doses. I just see way too many people on too high of dose medications, and too many of them. And again, I can't help but getting up on some soapboxes when I'm getting on a platform. So what are our overarching goals for treatment of first episode? Dr. Nasrallah, who I mentioned earlier, huge influence on the way I think about not only first episode, but schizophrenia in general, has a tremendous acronym called RAPID. And if you remember the acronym FAST from the treatment of a stroke, how we should react fast. Well, in schizophrenia and in acute psychosis of any kind, we need to think rapidly. Got to stabilize the patient and protect the brain, because there is damage that can occur. So we initiate antipsychotic therapy in our first episode patients, and we can talk about choices in a minute. Oh boy, I'm really getting close to time. And coordinated care programs. Now, these are not everywhere. They, unfortunately, they are relatively few and far between, but it has a whole treatment team approach, wraparound services, including primary care, case management, psychotherapy, support employment, family support, and education. And the reason why we need to think rapidly is because the clock is ticking. There is progressive brain tissue loss with each acute psychotic episode. Some estimates put it at about a teaspoon. That there's potentially a teaspoon of brain volume lost for every psychotic episode. That should boggle your mind. That should really make you stop and think, this is real. You know, some people say that psychiatric illness is all in your head. Well, of course it's in your head. That's where the brain is. And that brain is shrinking. That brain is burning. And we need to prevent relapse by any means necessary to prevent that downward functionality trend. So low and slow is what we usually say for geriatrics, but really we need to think about that in terms of antipsychotics as well. Table on the right that's compiled, these are some of the recommended doses for first episode psychosis. These are not starting doses. These are what you should be the goal or target dose of medications on average. You know, there's obviously plus minus, but these are significantly lower than what we're used to thinking about for schizophrenia, lower than the package insert. If you go solely based off the package insert for first episode patients, you will be wrong. The trials which get antipsychotics approved in America and worldwide are not conducted on first episode patients. They are conducted in patients who are not antipsychotic naive. They generally have a much more chronic history. So if you go by the package insert and use that cookie cutter one size fits all approach, instead of saying it depends and it's more complicated than that, you will get it wrong in first episode psychosis. So how do you get it right? Well, therapeutic drug monitoring is a tremendous tool. There was a task force which released some recommended levels and evidence levels for different antipsychotics and their correlations with blood level. As you can see here, some have better evidence bases than others. And also you can see over to the right, the consensus statement talks about cytochrome CYP enzymes involved in the metabolism of that medication. Now, it's an absolute, we know what the blood concentration is if we put a needle in someone's arm and draw it, but also we can potentially use someone's metabolizer status to enable some better choices as well. That includes both the person's genetic contribution as well as thinking about phenoconversion. Are they on medications that are inducers or inhibitors of these antipsychotic medications? So there's a couple different antipsychotic formulation options that we have to think about for getting back into some of the pharmacogenomics. Traditionally, oral medications have been the mainstay, but there are some issues with oral meds. Peak trough ratios are very high. Those of you who are clinicians, everyone out there has patients of every diagnosis who have said the medication wears off too soon. That I feel like it's running out before the end of the day, before the next dose is due, whatever. And peak trough ratio can explain some of that potentially. Also potentially adverse reactions. If there's a very high peak at the maximum concentration each day, can potentially lead to adverse reactions. There can be a lot of inconveniences to it. Food or drink restrictions with some antipsychotics. Some require multiple doses per day. Long-acting injectables. These we need to consider as opt-out only. Overall, I think we need to put all options on the table and use a shared decision-making approach with patients. And long-acting injectables have to be a part of that discussion, not just for people with chronic schizophrenia, but in first episode patients. We need to the patient should have to opt out of getting an antipsychotic, a long-acting antipsychotic, and we should be thinking of them by default, in my opinion. There's significant evidence to show greater outcomes with long-acting injectables. Relapse rate decreased, and these are not just compared to placebo, but there is evidence from meta-analyses that have been done which show compared to the same antipsychotic of oral formulation in many cases. Relapse rates improvements, mortality risk, rehospitalizations, incarcerations, there's significant benefits to the use of long-acting injectables. The blood levels are much more consistent with LAIs, especially the longer the interval between injections. And we know the adherence status perfectly. If the needle went into their arm and the plunger was depressed, then, or the arm or any part, whichever part of the body it was being injected into, I should say, if the needle went in the skin and the plunger was depressed, the person took their medication and it's going to be valid for however long that particular antipsychotics interval is, as opposed to oral medications where there's a lot of ways of measuring adherence to oral medications and none of them are flawless, whereas long-acting injectable antipsychotics are flawless. We know if they took it or not, if they showed up for their injection or not. And recently there has been a third formulation available, a transdermal one. Now, transdermal delivery does give very consistent and sustained medication delivery with low peak to trough ratios. It does have some visible confirmation of adherence. You can see if the patch is on their skin, if they show it to you. There could be some drawbacks. The adhesion, we're talking about adherence and adhesion, two different things, that the adhesion of the patch to the skin can be difficult sometimes. And at this point, there's only one molecule out of the dozens that are available. Now, getting back to figuring out what the right dose is, we don't want to over medicate our patients, as we mentioned. There are some pharmacodynamic genes that can shed some light. I mentioned there's going to be phenoconversion, but let's look genetically about it. So the cytochrome P450 system, as mentioned, there are multiple different metabolizer statuses. The PM poor metabolizer, you can see up top, they have a peak much greater than the green EM, extensive or normal metabolizer. Intermediate falls partially in between. And then ultra rapid metabolizers that are faster metabolizing the medication, they burn it off before it can really do what it needs to do. Again, this can look like non-adherence in the ultra rapid state. someone could be taking their medication, but they don't get a benefit because their body is metabolizing it too quickly. People with intermediate status, generally, we don't adjust our prescribing patterns to people who are intermediate metabolizers, but the poor metabolizers, their maximum concentrations, their area under the curve can be several multiples of what the person with normal metabolism has, twofold, threefold, fourfold, potentially greater. And again, when we've discussed the guidelines and evidence recommends we should be dosing for tolerability, and I didn't mention, but bar clozapine, there is no evidence that any antipsychotic is more effective in aggregate than any other antipsychotic. There's individual variation, obviously, some work better in some patients, but globally, then antipsychotics, again, safe clozapine, all have equal average efficacy. So especially for first episode patients, we should be dosing for selecting the medication first and then dosing it for tolerability. We want to create a good first impression of medication because this is a chronic lifelong illness that they will need chronic medication for in the case of progression to full schizophrenia. And so if they have terrible experiences up front, it could really color their impression of medications and cause them to become more likely to be non-adherent, which is the risk is high anyway. Now, in addition to cytochrome P450, which is phase 1 metabolism, phase 2 metabolism is by glucuronidation, and some other processes which enable the final excretion of the medication. There are some pharmacokinetic genes which can have some polymorphisms that can be looked at as well, but I left that off the slide. Then the one on the right, I thought I'd have more time by the time I got to this slide, the P-glycoprotein encoded by the ABCB1 gene. That's not how the body metabolizes the medication, but the P-glycoprotein transporter is basically one of the body's lines of defense to try and keep everything out. It tries to keep medications or toxins or xenomorphic materials from getting from the intestines to the bloodstream, tries to keep it from the bloodstream from getting into the brain, across the blood-brain barrier. And there are polymorphisms in P-glycoprotein in the ABCB1 gene, which can lead to greater absorption at the same dose of certain antipsychotics. And unfortunately, they are 4 of the most commonly used antipsychotics, especially in the seriously mentally ill: aripiprazole, clozapine, olanzapine, and risperidone can have, as studies have shown, increases in absorption across through PGP with polymorphisms. There are some pharmacodynamic associations that I find to be less useful than the pharmacokinetic ones, but I thought for completeness, I'd throw some out there. I arranged them in order, and these are ones that are relevant to schizophrenia. You can see the sample size. Some are small, some are relatively large. And the effect size I arranged in ascending order. So from a relatively small 0.65 for DOD2 to the bottom 2, which these ones I do find often clinically useful, MCR4 and serotonin 2C, those have to do with antipsychotic weight gain. The weight gain, as I mentioned, is very significant for all patients, but more in first episode, and nothing will make someone stop taking the medication faster than gaining weight. And using these pharmacodynamic associations could help us with a risk prediction, not after the fact, but before the fact. What are their odds? Are they going to be someone who takes olanzapine and gains tremendous amount of weight? Or are they going to be someone who takes olanzapine and has little to no weight gain? Because we've seen them both, and we don't want to be so afraid of prescribing to the former group that we don't prescribe to the latter group of people who would not have gained much weight. And this could be one way that we may consider adding to the rest of the sum of our decision-making to help make that decisions. And it's crucial because people with severe mental illness have greater degrees of comorbid conditions like dyslipidemia, cardiometabolic disease, hypertension, diabetes, other medical issues at baseline, unmedicated. And so we need to pay attention to that. I like to say, what's the use of saving someone's life psychiatrically? To let them die 10 to 15 years earlier from cardiovascular disease. Cardiovascular disease is the #1 killer of people with severe mental illness, just as it is in the non-mentally ill population. And numerically, most studies show a greater numerical number of excess deaths than suicide. We consider suicide an emergency. We need to consider comorbidity an emergency as well. we need to initiate the workup for the physical comorbidities at the first episode, at the same time as we are stabilizing them psychiatrically, not after they get psychiatrically stable. We need to do it concomitantly. And there are some guidelines that can give us some guidance into that. One way that we can get better outcomes are through coordinated care programs, which I mentioned earlier. As I said, they're few and far between, but SAMHSA has a locator. You can see if there's one in your local area that you can refer to at the website listed there. Stigma is something we have to combat. Schizophrenia, as I mentioned, is a brain disorder. And no one looks at anyone with a neurodegenerative disease such as Parkinson's, Alzheimer's with judgment. They look at them with sympathy. No one says, oh, I wish they would just get over it. I wish they would just go away. Why do we have to deal with that? What's wrong with those people? I don't think that's our problem. That's what people say. Those are opinions that many people unfortunately hold about people with schizophrenia. But schizophrenia is no less a brain disorder than Parkinson's or Alzheimer's. It's just that society has chosen to look at them differently in many cases, and we need to actively combat that because stigma is potentially fatal. So to kind of summarize, we have to make the diagnosis accurately and timely, early, initiate the antipsychotic, do it with shared decision-making, prioritize the tolerability, go very low and slow, and we should be offering LAIs by default, and therefore, I didn't mention, but we should give preference to initiating oral antipsychotics that have a long-acting injectable counterpart that the patient can be transitioned to if and when tolerability is assessed. Don't necessarily need to wait for efficacy to initiate long-acting injectable antipsychotics. As I mentioned, it takes a while for efficacy many times, usually longer than, almost always longer than a inpatient hospital stay. So you can't wait for someone to have a robust response to oral antipsychotics before starting LAIs. You have to start relapse prevention planning on day one because almost certainly this person will have future relapses and they need to be in on that as well. To mobilize the family support to do the above, and formal psychoeducation. This is not just teaching them during sessions. Psychoeducation, formal programs exist in some locations, and if you can find one, or just make the time yourself, have psychoed sessions with the person living with the illness, with their family. That coordinated care program is wonderful. You can find one. And finally, manage those physical comorbidities proactively and concurrently. If you can't get the patient into a coordinated specialty care program that has primary care support, if you don't have a primary care doctor provider in the area who works well with psych patients, if the patient won't see another primary care provider because you have the relationship, you have the access, well, you also have the medical knowledge. And there are certain physical comorbidities that we as psychiatrists, psychiatric nurse practitioners, physician assistants are qualified and within our scope of practice to manage if we do put in the elbow grease and put in the work to study them and learn the risks and benefits, because otherwise they may not get treated for diabetes, hypertension, dyslipidemia. We've got to save their life medically, physically, and psychiatrically. And most importantly, we have to foster hope. I've always said the most important thing that a physician or any provider can give a patient is not a prescription, it's hope. It has to be a realistic hope and not a false hope, but it's our job to instill that sense of hope. But in order to do that, we have to have hope for our patients, and we need to raise our bar of the standard of care so that they raise their expectations of themselves. So I didn't leave nearly enough time for Q&A. Hopefully maybe some people can stay over. So I'd love to start taking those questions.
Okay, great. Thanks, Dr. Chepke. So we have a couple of questions. I have a question for you as well. You listed some of the usual suspects there in your chart when it came to different antipsychotics. Can you talk briefly about some of the new kids on the block, the lumateperone, cariprazine, but also the brand new kid on the block, which is the combination olanzapine, samidorphan?
Yeah, absolutely. So one thing is that we need to keep every arrow in our quiver when it comes to treating schizophrenia. We should know about every medication because every medication has a place with some patient. One thing specifically that most of the new antipsychotics have in common is a focus on increased tolerability, really. The efficacy, as I said, has not been shown to be significantly different, but tolerability in most cases has been. So cariprazine has an excellent metabolic profile is one of its claims to fame. There is some evidence, although not in the package insert, that indicates it could have some greater efficacy for negative symptoms potentially. Again, that's not in the label for the drug, but it could be possible. So you mentioned also lumateperone. Lumateperone, another one, has tremendous improvements in the metabolic area. Short-term studies, long-term studies, which meaning 1 year, look very good so far. Also significant there is that the motor side effect profile is outstanding, comparable to placebo in all the short-term motor adverse reactions, akathisia, dystonia, Parkinsonism, which while criprazine is not terrible in those regards, for some patients, there still is a couple percentage points where they were developed in the trials. But lumateperone looks outstanding, and in clinical practice so far I've seen as well. I do a lot of work with movement disorders, so I screen for it very diligently, and it's got an excellent profile. So olanzapine samidorphan is really fascinating to me. Who doesn't love a second chance? And this is the second chance for olanzapine. Olanzapine was, during my training, it went generic a year or so after I finished my residency training, was really demonized in my residency program because of its metabolic and weight gain adverse reaction profile. And I got out of training and got into a real job. And I found that anecdotally, there were many patients I saw who that was the only thing that got them better. And when I mentioned that we're so afraid of prescribing to the people who might gain so much weight, we don't prescribe to the people who unknowingly wouldn't. I look at that as a way that we can maybe tip those scales back. The addition of the samidorphan in the registration trials was shown to improve the weight gain and potentially start to bend the needle on the metabolic effects of it. Hard to tell from shorter term trials, but I think it's very interesting. And olanzapine is one of the few antipsychotics that is even approaching clozapine in terms of evidence level of having a potentially superior efficacy compared to all the other antipsychotics. Although again, clozapine stands head and shoulders above anything, olanzapine is at least reaching for the stars. And to be able to potentially use more of a drug that is considered by many experts to be a highly efficacious one, I'm really intrigued by that possibility and looking forward to its availability later this year.
Okay, thank you. Maybe we have time for 1 or 2 questions from the audience. Can you differentiate physiologically the difference between bipolar psychosis and schizophrenia psychosis?
That would probably take more time than we've got. You have to look at, does the person have psychosis in the absence of any mood symptoms? That's really the key thing that I would say, is that do they have the psychosis only during periods of mood instability, if mania, I believe is the way the question was asked, or does the psychosis occur without any evidence of any mood disturbance at all?
Okay. And then a question about antipsychotic use in children. I'm not sure if you treat children or not, but my own follow-up to this question is, if you recognize this prodromal phase early enough, is there anything you can do to delay progression to full schizophrenia?
Yeah, I mentioned I left out the clinical high risk and ultra high risk categories, and there's been tremendous research. So what you can do, one, most of it is non-pharmacologic, honestly, that are the best things you can do. Stress levels have been shown to increase the risk of transition from the ultra high risk or clinical high risk, we'll just call high risk, the high risk states, to having symptomatic, syndromatic psychosis. So that can occur not just giving them an easy life, but family therapy and reducing the stress there. Are they in a challenging psychosocial, socioeconomic status? Are there ways that situation can be improved? The use of antipsychotics in the high risk state before they have developed any psychosis has not been demonstrated to actually be disease modifying. So that is not recommended. It was widely hoped and somewhat believed for some time that omega-3 fatty acids could play a role in reducing the transition from high risk to the syndromatic psychosis, but more recent studies have thrown cold water on that. So it is now believed that omega-3s, while still good for many aspects of health, are not efficacious to change the outcome of someone in the high-risk state and prevent them from developing psychosis statistically. There's still a question, the jury's out about other possible neuroprotectives, some antioxidants, N-acetylcysteine is another one where we use a lot of it in various psychiatric illnesses, and we really need more research, but I think that would not be an unreasonable thing to do for someone who's in that high-risk stage.
Okay, well, that puts us right a little bit past the hour, so I think that's it for Q&A, and we apologize for not getting to all your questions, but I'd like to thank Dr. Chepke. It was a fantastic presentation here. And this webinar will be posted on genomind.com/360, and if you have any questions for the Genomind team, feel free to send an email to medicalaffairs@genomind.com. So Dr. Chepke, thank you. We appreciate your time and insight today.
My pleasure. I appreciate everyone for logging in for the benefit of your patients with schizophrenia. Again, raise your bar, do more, help them. They deserve it.
Thank you. Great parting words. Take care.
Bye, everyone.